Sir, I'll just try sharing my screen.
Yeah. Generally, it works in Zoom quite easily. It doesn't work in the Teams. We can see your screen.
Is it okay, sir? Screen is visible, sir?
It is.
Unknown caller.
Hello.
Sir, emergency hospital. Sir.
Hello, join the meeting, right? I'm showing my face, but I'm not able to hear the audio. I just wrote the stop jam. When we going to stop the video now? Video will stop. No, everyone is showing video. Yeah. Best. Yeah, tell at home or room or somewhere. That's all. Blur the behind video. Yeah.
Okay. Shall we start? It's 7:30. Samreen, can we start or wait? More minutes. We'll wait for 1 more minute, then we'll start.
So we can start now. I think 7:30.
Okay. Good evening. Welcome, everyone. I'm Dr. Sanjay Edla. Today in the Back to Basics, we will try to learn about castrate-resistant prostate cancer. And hopefully at the end of this 1 hour, not only do we understand the theoretical basis of CRPC, but we'll get some practical solutions as to how to manage these patients when we see them from tomorrow. Okay, I'll hand you over to Dr. Ravi Chandran. Ravi, you can take over. You're muted, or at least this speaker is muted.
Good evening, sir. Am I audible?
You are audible. Yes.
Thank you, sir. Thank you, Sogo. Thank you, Sanjay, sir, for this opportunity. So as a continuation of Back to Basics, today I'll be talking about principles of management of castration-resistant prostate cancer. In the last session, my colleague Dr. Arun had spoke about management of castration-sensitive prostate cancer, and I'll be focusing on CRPC. To begin with, I have divided my first 30 minutes, following which there will be a case discussion with 3 panel members. To begin with, we'll be talking about natural history of prostate cancer, wherein how to begin with, it will be a localized disease and it then goes on to become metastatic, initially being sensitive and eventually castration resistant. And then the multiple treatment options which are there spanning across the spectrum of the disease. Followed by which we will talk about molecular mechanism of CRPC development, which remains an enigma. I'll try to make it as simple as possible for our understanding. And then we talk about definition of CRPC and then the patient selection. With multiple treatment options in hand, we'll see what is the right treatment for the right patient. And then we look at the treatment landscape spanning from our veteran docetaxel up to the current newbies like PARP inhibitors. And then with so many treatment options, with so much armamentarium in hand, as how do we go about sequencing these drugs? And finally, last 30 minutes, we will have a case discussion. To begin with, we'll talk about natural history of prostate cancer. So as you can see here, to begin with, majority of our patients will be detected at a non-metastatic state and then go on to become a metastatic disease. And majority of them will be hormone sensitive and eventually will develop castration resistant state. We have read a lot about natural history, and it still remains partly understood concept of the whole prostate cancer, probably due to the heterogeneity in its morphology and in its clinical behavior. In our clinical practice, we would have seen a lot of prostate cancer patients outliving the disease. And on the same breath, we have seen a lot of patients quickly succumb to the disease, especially the CRPC setting. And here we can see in the local stage and locally advanced stage, there are three important players: surgery, radiation, and with new entrant surveillance, all trying to dwell the same space, jostling for their prominence. However, it is at the end of the spectrum near the CRPC where the space is getting crowded, with new entrants like lutetium PSMA making a huge bang, and with recent onset of these PARP inhibitors also trying to occupy the space. Well, here I have just briefly summarized trials and drugs used in metastatic castration-sensitive prostate cancer. As we can see, to begin with, we were having monotherapy as a primary treatment. Probably 15 to 20 years back, if we had to talk about treatment of metastatic CA prostate, it was just ADT as a monotherapy. And then in the first half of 20th century, we had docetaxel coming into picture. And in the later decade, we had novel androgen receptor inhibitors. And now in last 3-4 years, we are having multiple trials showing better results with triplet therapy. And this one picture I have borrowed from last presentation from Dr. Arun Menon, wherein here we can see he talks about having hurry it and hit it hard, because ADT resistant subpopulation will be smallest to begin with. So hit it hard there and then hit it hard so that we have a better tolerability and better performance score status of the patients to tolerate this treatment. So with this triplet therapy coming into picture, the moment patient goes into resistant state, we somehow feel the treatment options in hand would get narrow. However, today we will try delving into multiple treatment options which we have in hand, and how to use it for right patient and how to sequence them. Coming to molecular mechanism of CRPC development, first let's try looking at how the prostate cancer mechanism goes about. We have predominantly two sources of testosterone, that is testis and adrenal. Testosterone gets converted into the most active molecule, that is dihydrotestosterone. It gets binded to androgen receptors in an intracytoplasmic level. And this androgen receptor ligand combination will go on to trigger androgen receptor envelope inside the nucleus, triggering an excess of transcriptional activity, wherein there will be more PSA, more growth, and more survival of cancer cells. This is a brief basics behind the development of a prostate cancer. However, there are 5 possible pathways of castration resistance. This is from Campbell. So of the 5 pathways of castration resistance, first is hypersensitivity. These androgen receptors will become hypersensitive to whatever the minute element of testosterone is available in the body. That can either happen because of androgen receptor mutations, androgen receptor overamplifications, or these androgen receptor splicing variants. So that is first thing, hypersensitivity of the receptor in itself for the ligand. The second is promiscuity of androgen receptors. All the while they were responding for dihydrotestosterone, but now suddenly they start responding for other elements like corticosteroids. So there is a promiscuity of androgen receptors in order to trigger the transcriptional activity. And next is the outlaw model, wherein the other growth factors like epidermal growth factor, insulin-like growth factors kick in and they increase the transcriptional activity. And next is bypass model. Here somehow androgen receptor bypasses this natural pathway of having to bind with dihydrotestosterone. Probably there will be a more of intracrine biosynthesis of testosterone, leading to triggering of androgen receptors and hence transcription activity. And last is Lurker cell theory, where they propose that there is a small element of these epidermal stem cells within the prostate, wherein this gets kicked in when the androgen levels go down. So these are the 5 possible pathways wherein castration resistance can kick in, leading to development of CRPC status. Next, coming to definition of CRPC. Yeah, coming to definition of CRPC, the first thing to establish in CRPC setting is to make sure that testosterone level is at castration, that is less than 50 nanogram per deciliter or 1.7 nanomole per liter. Along with that, there has to be either a biochemical progression or a radiological progression. What does define a biochemical progression? 1, there has to be a 3 consecutive rises in PSA at least 1 week apart, resulting in 250% increases over the nadir, and PSA has to be more than 2 nanogram per ml. What defines a radiological progression? There has to be appearance of a new lesions, either 2 or more new bone lesions on a bone scan, or a soft tissue lesion using RECIST criteria. The symptomatic progression alone must be questioned and subjected to further investigation. Symptomatic progression alone will not be sufficient to make a diagnosis of CRPC. To make it simple, first, we have to establish the testosterone level have reached castration state, that is less than 50 nanogram per deciliter. And then we have to look for either rising PSA or we have to look for a radiological progression. What defines rising PSA? PSA has to be more than 2 nanogram per ml with 3 consecutive rises at least 1 week apart, resulting in 250% increases. So one thing to notice here in the definition of CRPC is that the radiological progression is assessed using a bone scan, and the soft tissue lesions are assessed using cross-sectional imaging like CT or MRI. They don't include PSMA PET CT here, where in India we've been using PSMA PET CT, which is freely available. So PSMA PET CT is not a part of a definition of CRPC. We will be looking into this aspect later in the clinical discussion part. Next, coming to treatment landscape for metastatic CRPC, this is from NCCN, wherein we can see they have divided the setup in 4 portions. One, that there is no prior docetaxel or no prior novel hormone therapy, and then only docetaxel is given, or only novel androgen receptor inhibitors are given, or when both of them are given. And as you can see here, the classes of agents which are used range from cytotoxic to latest PSMA theranostics. So with so many medicines, with so many options in our armamentarium, it is crucial as how do we make a patient selection. The first thing to look at is the patient and his comorbidities. What is his performance status, whether he's symptomatic or asymptomatic. If symptomatic, whether it is mild or if he's severely symptomatic. We also look at whether there is a visceral or non-visceral metastasis. By and large, in CRPC, the prevalence of visceral metastasis is low. It's predominantly bony and nodal metastasis. However, we need to make a differentiation on that. And next comes the crucial part of it, where what was the previous treatment given? Was it a chemotherapy? Was it a novel androgen receptor inhibitor? Because there is a cross resistance between these treatment options, and we need to look at it. And how quickly did the disease progress while on this treatment? How do we sequence the drugs? How do we sandwich the available treatment options is more important. And now with the recent onset of PARP inhibitors, we need to know what is the genetic alterations, whether there is any microsatellite instability is high, if there is any mismatch repair deficiencies, if there is any DNA repair deficiencies, have to be looked upon in order to look at options of PARP inhibitors. And the next thing is to know histological variants. When we say histological variants, primarily we are talking about neuroendocrine differentiation, wherein the role for novel androgen receptors or PARP inhibitors is almost nil, wherein chemotherapy takes a center stage. And at the end of it, the local approval status of drugs. Though in guidelines and protocols, we look at multiple treatment options, we also need to look at the local availability of it and available clinical trials. and make a suitable selection for our patient group. Next, coming to the role of molecular diagnostics in a CA prostate, all metastatic patients should be offered somatic genomic testing to look for homologous repair, which has a prevalence of about 23% in metastatic state, and to look for MMR defects, which is about 5% in metastatic state. This is very crucial. Though in NCCN guidelines and EAU, we read about genetic testing and molecular diagnosis starting from very high risk and high risk population, I think a bare minimum in our setting, all metastatic patients, especially CRPC setting, should be offered somatic genomic testing. And then we can look for defective MMR assessment by doing IHC for MMR proteins like MSH2, MSH6, MLH1, and PMS2, or we can get next generation sequencing assays. And then we have to look for germline or tumor testing to look for mutations in HRR genes, where we can see up to 12% of metastatic CRPC patients will have defect in HRR. There are mainly 12 or 16 of genes. The most important ones would be BRCA2 and ATM. And finally, we can look at tumor metastatic burden testing. If tumor metastatic burden is more than 10 MB, then there is a possible use of pembrolizumab. Though the data on CA prostate is limited, this is primarily as a last resort. Looking at the unmet clinical needs or the latest things which is happening in the trial space, that is CDK12 mutations, wherein these mutations tend to be very aggressive with high rates of metastasis and short overall survival. And they usually have poor response to all treatments except pembrolizumab and nivolumab. So to brief about molecular diagnostic in CRPC, the key is all CRPC patients get somatic genomic testings and germline testing, bare minimum IHC for MMR proteins. And this pembrolizumab and nivolumab, they're all last resort options we have. Next. Coming to treatment landscape for metastatic CRPC, I was discussing with Sanjay sir about this treatment landscape for CRPC, and sir was saying like before 2000, hardly we had any options. There was just mitoxantrone. You give mitoxantrone, which carries a lot of side effects. If he's tolerating it and if he can complete a treatment, well and good. Otherwise, the only next option patient had was best supportive care. But come 2004, with two trials, SWOG and TAX327, docetaxel entered the scene, showed a huge OS benefit, and then there is no looking back. Docetaxel occupied a center stage and was beneficial for most of CRPC setting. From 2004 till almost a decade, till about 2013 or 2014, there was hardly any development except for cabazitaxel showing some benefit for patients. For almost a decade, it was just docetaxel and with cabazitaxel in between. But in 2013 and 14, entered abiraterone and enzalutamide and other novel androgen receptor inhibitors, and they formed a first line of management for CRPC setting. And in last 2 to 3 years, this space is getting crowded. With 2021, PSMA-based theranostics entered a scene, showing a huge OS benefit, wherein it looked like it was altering the natural course of prostate cancer. And in 2023, probably in last couple of months, there have been 3 to 4 big trials bringing PARP inhibitors with or without novel androgen receptor inhibitors into first line setting for metastatic CRPC. So one after the other, in this sequence, we will try looking at all these options. What are the trials that led to FDA approval? What precautions do we take? And later, how do we sequence these medications? To begin with, we'll start with our veteran, that is docetaxel. There were 2 randomized phase 3 trials which were evaluated in symptomatic and or rapidly progressive CRPC, SWOG 9916 and TAX327 studies. These 2 studies showed a huge OS benefit. And in these 2 studies, the comparative arm was mitoxantrone, which was a veteran being used before docetaxel. In both these studies, the docetaxel dosage was 75 milligram per meter square, usually 3 weekly. And this regimen had a bit of side effect profile. So there was another trial looked at every 3-week docetaxel was as a bi-weekly regimen of 50 milligram per meter square. And this was evaluated in a large randomized phase 2 trial though. Overall survival, time to progression, PSA decline rate, and tolerability was improved with biweekly docetaxel. And then there was another confusion saying 6 cycles were being used in castration-sensitive prostate cancer, and 8 cycle is by and large a standard in CRPC setting. There have been trials looking at whether 6 cycles is enough or do we need to really go up to 10 cycles. By and large, docetaxel 8 cycles seems to be standard of care, with about 75 milligram per meter square being a 3 weekly 75 milligram per meter square being a standard. Next, coming to cabazitaxel, in 2010, FDA approved cabazitaxel in metastatic CRPC setting, especially in those previously treated with docetaxel. It was based on a phase 2 trial, that is TROPIC, wherein TROPIC was combined against mitoxantrone was prednisolone. And here we can see OS at more than 2 years was 27% compared to 16%. Another phenomenal trial, CARD, which was published in 2019, it was set in a patients wherein previously they had docetaxel and also on a prior any of the novel androgen receptors. So the standard arm was cabazitaxel with prednisolone with colony stimulating factor, and the comparative arm was either abiraterone or enzalutamide. And here, as you can see, median OS was 13.6 versus just 11 months, and the radiation progression-free survival, radiology progression-free survival was 8 months in comparison to 3.7 months. Well, there are 2 other studies associated with cabazitaxel. One is ProCelica study. It's a phase 3 study wherein it's a non-inferiority study comparing 20 milligram per meter square of cabazitaxel against standard of 25 milligram per meter square. Median OS was non-inferior. Grade 3 and grade 4 adverse events were decreased. Cabazitaxel had a problem of severe febrile neutropenia. So they evaluated in ProCelica saying, let's reduce the dose and see if it is better. Certainly, median OS was non-inferior and adverse events seemed to be less. The other trial is Firstana, which is a phase 3 study looking at the activity of cabazitaxel in a chemotherapy-naive metastatic CRPC setting. As you can see, both TROPIC and CARD, they are in a previous docetaxel setup, whereas Firstana study is in a chemotherapy-naive setting. The median OS between cabazitaxel and docetaxel did not make much of a difference. Next, coming to our abiraterone acetate. In April 2011, based on COU AA301 study, FDA approved it in a post-docetaxel setup. As you can see here, the OS benefit was 15.8 months compared to 11.2. Another study, COU AA302, this was in a pre-docetaxel, in a docetaxel naive patient. And again, the OS benefit was more and it was statistically significant for abiraterone. So do remember these 2 trial names. 301 is for a post-dosi setting and 302 is for in a previous docetaxel setting. In these studies, even the secondary endpoints were significantly favoring abiraterone. Coming to the side effects of abiraterone, we need to understand as how does abiraterone act and what leads to the complications which we see in day practice. One, abiraterone, we all know, is a cytochrome P inhibitor. So because of the cytochrome P17 alpha hydroxylase inhibition, pregnenolone gets stranded. And this pregnenolone is diverted towards more of production of aldosterone, leading to hypertension, leading to hypokalemia, hypophosphatemia, and peripheral edema. And since pregnenolone gets stranded, there is no downward pathway. Cortisol gets affected, leading to altered sugar values. And that is why for all abiraterone patients, we start them on some form of a steroid. And then eventually the dihydrotestosterone production does not happen. And that's how its mechanism of CA prostate works. Apart from hypertension, hypokalemia, and hypophosphatemia, one more thing which is important from our clinical practice perspective is increased ALT and AST. That has to be kept in mind. So how do we minimize side effects in abiraterone acetate and how do we maximize its efficiency? One, take it on an empty stomach. And then for all abiraterone, we do give prednisolone 5 mg BD or any other equivalent options. We keep a close eye on LFT because we know that there is elevated ALT and AST in dose setup. We look for potassium and phosphate levels, and we keep a close eye on blood pressure monitoring. It is looked upon either a week or 2 weeks after starting, and for a month, for at least first 3 months, to make sure that LFT is not getting deranged or hypertension is not creating a havoc. And then if at all there is an LFT alteration, if there is AST, ALT or bilirubin elevation, we can reduce the dosage until it normalizes and then restart at a lower dose. And as I've already mentioned, look for hypertension and fluid retention and treat it accordingly. There has been one phase 2 study where they have evaluated abiraterone at a 250 milligram per day dosage with a low fat breakfast as an alternative for a patient who cannot take abiraterone 1 gram or who cannot afford abiraterone 1 gram. Though it's a phase 2 study, it's more of a non-inferior setup. Next, coming to next drug, that is enzalutamide. In September 2014, based on PREVAIL study, enzalutamide was FDA approved in a post-docetaxel setting with benefit in both OS and radiological progression-free survival. And in August 2012, it had approved in pre-dosi setting based on AFFIRM trial. Please do remember these trial names and what were the primary and secondary endpoints. And apart from primary endpoints, even secondary endpoints were favoring enzalutamide. Coming to adverse side effects in enzalutamide, the most important one is profound fatigue. Fatigue seems to be the most common side effect leading to discontinuation or lowering the dose of enzalutamide, followed by hypertension and a rare posterior reversible encephalopathy syndrome, though incidence is very low. The dose of enzalutamide may have to reduce to 80 milligram if there are any concurrent cytochrome P2C8 inhibitors, like in gemfibrozil, probably in patients of diabetic or dyslipidemic. We have to keep a close eye. And enzalutamide may affect serum levels of other cytochrome P-inducing agents, like in warfarin. If there is a profound fatigue, do consider reducing the dose and be careful with the drugs that lower seizure threshold, like in bupropion or no seizure patients on medications, or however who have been free of seizure for a long time and not on any current medications. Be careful with enzalutamide. Next, coming to Sipuleucel T, less spoken better, not available here, nor do we use it on a regular manner in our practice. It was approved in April 2010 based on Impact 2010 study. But the importance of this study was to open up an all new Pandora's box, wherein there was a space for immunotherapy, there was a space for modulating immunity in order to tackle prostate cancer. So that way, we have to give a credit for Sipuleucel T for opening a new Pandora's box to tell us that there is a scope for immune modulation in treating prostate cancer. Well, it was a category 1 option for certain patients of metastatic CRPC who had not had any previous treatment, neither DOSI or novel hormone therapy. It's preferred in asymptomatic or minimally symptomatic patients. Next, coming to our new players like PARP inhibitors, there have been a couple of drugs like olaparib, rucaparib, and niraparib. Olaparib in combination with abiraterone was evaluated in a PROPEL trial. It was a phase 3 trial with an primary endpoint being image-based progression-free survival, which was significantly longer in the PROPEL trial. And not only that, there was an OS benefit in this combination in the intent to treat population, not only in people with HRR mutation or BRCA mutation, even otherwise in non-HRR mutation and in non-BRCA mutation subgroups, there was OS benefit. In this study, the combination of olaparib and abiraterone was used. All these PARP inhibitors come in a tablet format. Olaparib, 300 milligram BD, along with abiraterone, versus placebo versus abiraterone was evaluated regardless of HRR mutation. However, there was a substratification based on these mutation levels and analysis was done. So as already mentioned, irrespective of mutation status, there was a OS benefit, propping up this combination as a category 1 recommendation in first-line metastatic CRPC setting. Next, Apart from combination of olaparib with abiraterone, olaparib alone was also evaluated in a profound study. This was particularly evaluated in a patient who had a previous novel androgen receptor inhibitor and who had alterations in HRR mutation. As we can see, it did had a OS benefit and radiological progression-free benefit. Next, coming to combination of talazoparib and enzalutamide, which was evaluated in TALAPRO-2, and it was FDA approved for HRR mutated metastatic CRPC patients in June 2023. As you can see here in this graph, that the combination was performing better than placebo plus enzalutamide. So it has become a category 1 recommendation for those without prior DOSI or a prior novel androgen receptor, and a category 2A recommendation for those who were already on prior docetaxel in CSPC setting. And the next combination is niraparib plus abiraterone, which got an FDA approval following magnitude study. It got approved in August 2023, just a couple of months back. It had a more benefit in mutated subgroup patients, but even otherwise, it did have a OS benefit, and it did have a radiology progression-free survival in intent to treat overall population as well. So for all these three combinations of olaparib plus abiraterone, niraparib plus abiraterone, and talazoparib with enzalutamide, they all have been propped up as category 1 recommendation in metastatic CRPC, irrespective of mutation status. And finally, we have rucaparib in metastatic CRPC based on TRITON2 trial. There is no need to remember all the eligibility criteria, what are the primary and endpoints. At least if we can remember the drug, the trial which has led to FDA approval, and what is the category of recommendation, that would be good enough. And after PARP inhibitors, the new entry into the scene is PSMA-based radioligand therapy. Here, after identification of target, usually it is done with a diagnostic 68 gallium-labeled PSMA. A therapeutic radiopharmaceutical is labeled, that is either lutetium-177 or yttrium-90, or an alpha-emitting isotope, that is actinium-225. Predominantly, lutetium-177 has been used in trials. This was a picture which was presented in European Society of Nuclear Medicine back in early 2018. Wherein, as we can see here, there was an extensive skeletal metastasis, extensive nodal metastasis, and following 177 lutetium PSMA therapy, how progressively a patient has responded so beautifully. And on the other side, we can see the percentage PSA change following lutetium therapy. This study was phenomenal and landmark for that year of annual conference of European Nuclear Medicine. Well, there have been 2 trials which have been key in bringing lutetium PSMA into mainstream. One is Vision trial published in 2021, wherein lutetium PSMA along with the standard of care was compared with standard of care alone. And as we can see here, imaging-based progression-free survival was better, and so is overall survival. This overall survival data is where we get convinced that this is one option which can really alter the natural history of metastatic CRPC patients. Well, both these trials were predominantly done in patients with PSMA positive metastatic lesions with limited evidence, if at all, there is a PSMA negative lesion. And the second study is THERAP, which was published in 2021, wherein there was randomization between lutetium-177 versus cabazitaxel. This was one trial which gave us a little more clarity when it came to third line of management, as in whether if we have to choose for lutetium PSMA or if we have to choose for cabazitaxel. The gist of this THERAP trial is that if there is predominantly PSMA positive metastasis with no PSMA negative, then lutetium PSMA is a little superior compared to cabazitaxel. Next, coming to radium-223, this was based on an ALSYMCA trial. We don't practice it often here. This is predominantly for patients who have symptomatic bone metastasis and no known visceral metastatic disease. If a patient has bone metastasis alone, then radium-223 is a good option. But one thing to be careful about, hematological side effects associated with the radium-223 severe marrow depression. Coming to pembrolizumab, pembrolizumab is a last drug resort. FDA had approved pembrolizumab in treatment of patients with any unresectable or any metastatic solid tumors which have MSIH or a deficient MMR. Any solid tumor, it was FDA approved. In this study, which was published in 2017, hardly there were a couple of prostate cancer patients. But by and large, as a last resort, FDA approval was given. There was one more trial in June 2020, wherein they looked at the tumor metastatic burden. And if tumor metastatic burden was more than 10 mutations for megabase in a solid tumor, pembrolizumab can be used as an absolute last resort option. Next, so we've completed all the treatment options, the drugs and PSMA-based theranostics and PARP inhibitor-based theranostics. This is the gist of NCCN guideline for CRPC. As we have already summarized, the first thing to do is to have a metastatic lesion biopsy, get a tumor testing done for MSIH or dMMR, and look for if there is any DNA repair deficiencies. And if possible, try to look for TMB testing in case if you have to use pembrolizumab as a last resort. Following that, what are the treatment options? One, to continue ADT. This is where the confusion starts. We've labeled it as a castration-resistant prostate cancer. Then what is the need to continue ADT at all? There are a couple of studies spanning back in 1990s where they have looked at continuing ADT in CRPC setting, and they concluded saying the benefit outweighs the risk. So to whatever it is worth, just continue ADT in all these patients. And if you see all the trials which we have discussed so far, ADT was there as a part of a treatment option. So along with the ADT, we have multiple treatment options which we have discussed. And in a short while, we will look at how to sequence these options. And as we've already seen, if at all there is a small cell differentiation, only treatment option is chemotherapy, preferably cisplatin and etoposide combination. There is no role for hormone or no role for PARP inhibitors in neuroendocrine differentiation. Well, this is the flow chart which I have prepared based on currently available guidelines and recommendations. So there are four scenarios which we encountered in our clinical practice. One, if patient so far had received only ADT as a monotherapy, in that setting, we have multiple options. One, docetaxel. We have abiraterone enzalutamide, both of our novel androgen receptors. And as I mentioned, all the PARP inhibitor combining with novel androgen receptor, all the three studies, all the three drugs have been made as a part of category 1 recommendation. And these not only in ADT monotherapy setting, even if patient has already received docetaxel, still these novel androgen receptors and PARP and combination seems to be a first category recommendation. In case these patients progress while on docetaxel or while on being on this combination, we can swap for docetaxel. Though there is some amount of cross resistance between swapping docetaxel to novel androgen or novel androgen to docetaxel, certainly benefit is still intact. The second thing is when a patient has been started on novel androgen receptor inhibitor, how do we go about? If there are no mutations, then docetaxel is an option. If at all they have a BRCA mutation or HRR mutation, along with docetaxel, even olaparib and rucaparib are options. Even they are category 1 recommendations in a first line setting. And if they progress while on olaparib or rucaparib, anytime you can then switch on to docetaxel. The last thing which we possibly encounter in coming days is when patient has already received triple therapy, and how do we go about? If at all they are having BRCA or HRR mutations, then we can use olaparib and rucaparib. Otherwise, those patients will straight away have to go for third line treatment setting. So what do we have in third line treatment setting? One is lutetium PSMA. Second is cabazitaxel. These two guys are the key players in third line setting, and there is an option of using radium-223 for exclusive symptomatic bone metastatic patients. And as an absolute last resort, we can have pembrolizumab. There have been certain proponents of having docetaxel rechallenge or having a combination of cabazitaxel plus carboplatin as well. So to just briefly summarize on a sequencing, if a patient is started on docetaxel, fails on docetaxel, you have an option of switching either to abiraterone or enzalutamide alone or a combination along with PARP inhibitors. And if they progress on that, then we go on for third line treatment. If patient is on just novel androgen receptor, you can either go for docetaxel or olaparib or rucaparib and then take a call accordingly. Whenever we are talking about CRPC setting, along with all these drugs, the main one more pillar which we should not forget is to add a bone protective agent in order to reduce skeletal related events, which I'll be talking shortly. So once we have triggered the patient on a treatment, how do we monitor them? One is to have a baseline examination, PSA. Once you document a total testosterone level, that should be good enough. Keep looking at counts, renal functions, and liver functions. Keep getting bone scans and CT scans if at all there is any symptomatic progression or PSA failure. Though there is no data on role of PSMA PET-CT in monitoring in mainstream guidelines, but I think in India we've been using it liberally. And one more thing is PSA alone is not a reliable enough monitoring of a disease activity, especially in advanced CRPC, because visceral metastatic patients may not really show rising PSA. Next, coming to non-metastatic CRPC setting, this is not really a part of natural history of disease. This is something which we often see in India, wherein patient with CA prostate goes on, gets a TURP done or gets a bilateral orchidectomy done, irrespective of the state of it, and then eventually they end up in a non-metastatic CRPC setting. And in all the trials, the definition of non-metastatic CRPC is one, rising PSA with castrate level of testosterone. And one more thing is not every non-metastatic CRPC patients needs to be treated. Only patients with PSA doubling time less than 10 months are the ones which require treatment. And in all the trials, the imaging modalities were just CT scan and bone scan. Probably if these patients were to have a PSMA PET-CT, probably they may really not be non-metastatic CRPC stating to begin with. And most of these patients will go on to develop bone metastasis within 2 years of initiating on treatment. There are 3 drugs, apalutamide, darolutamide, and enzalutamide, along with ADT in non-metastatic CRPC setting. These are the 3 drugs. Darolutamide got approval following Aramis trial, enzalutamide following...
Do you want to conclude?
Yes, sir, I'm concluding.
Yeah,
And
10 minutes,
yes, sir, following Spartan trial. Of the 3 trials, which is better? There was one retrospective based trial named DEER, which was done in US, which showed that darolutamide was a little better compared to other 2 drugs in terms of adverse events and as well as in terms of time to progression of metastasis. Finally, bone health management is crucial. The key factor here is to have a multidisciplinary approach, have a palliative team in hand. Any painful bone mets, consider EBRT. Any impending spinal cord fracture, compression, it's an emergency, a dire emergency. Recognize it early, get an MRI, get spinal decompression, if required, EBRT. And there are 2 drugs, zoledronic acid and denosumab. We will be covering it subsequently in our case discussion. We will highlight these factors when we come for case discussion. Well, I'll summarize it at the end of our case discussion, sir. Sanjay sir, shall we go ahead with the case discussion?
Yes, I just wanted to highlight a few things.
Yes, sir.
If the Alsimpa, which was the radium-223, so there were if I was looking at 4 landmarks from the beginning of the millennium to 2023, the first one was the 2004 docetaxel, which was the first one to show survival benefit in a CRPC setting. That's the first one. The 2013 Alsimpa trial, the reason why radium-223, though it is very expensive, was approved and was in use was mainly, again, it showed overall survival benefit. And though it was used for the symptomatic benefit, still it showed overall survival benefit. Then came the newer hormonal agents, whichever you use, any of them, enzalutamide or abiraterone acetate. And then the last one, the therapy study. Yes. If you look at the other ones, the control arm seems to be SOC or placebo. Therapy study had lutetium versus cabazitaxel, which is a very good control arm. Still, it showed survival benefit. Yes. So that's the reason the therapy is an important one, just because it shows that the PSMA directed therapy will come earlier and earlier. And probably if we had the same talk in 2 years' time, that would be the first thing that you would discuss, because it's a totally different modality of attacking the same problem. Thank you.
Sir, I would like to introduce my panel members. We have Dr. Varun from Bangalore, Dr. Preet from Delhi, and Dr. Gopal from Bangalore. My panelists, am I audible?
Yes, sir. Sir, yes, sir.
Fine. We will start with our case. Mr. RT.
Just keep a timer on. It will be 15 minutes because we have taken 45 minutes for the talk.
Done, sir. Done. We'll run through.
So try to progress and try to get the messages through in that time period.
Done, sir. Done. He's a 69-year-old gentleman, had underwent HOLEP for a lower urinary tract symptom. His pre-op PSA was 90. Which was not evaluated, and the post-op histopathology came about as CA prostate 5+4 disease. And without metastatic evaluation, he was started on injection pamorelin and Caluron elsewhere, and he has taken these medicines for nearly 2 years. And the PSA for about a year. And the PSA levels at 6 months was 0.021. At 9 months, it went up to 0.5, and in 12 months, it is 4.3. May I have Dr. Varun to comment what would you have done differently and what do you want to do next for this gentleman? Varun?
Yes, sir. Yes, sir. Yes, sir. Sir, initially, I would like to get a detailed history, sir. I want to assess family history also and performance status. And later, I want to do examination, that is DRE as well. I would like to get the slides of previously done surgery. Because it is our institutional protocol, and to get it reviewed. And also Gleason's is 5+4, sir. And also I want to look for neuroendocrine differentiation by getting IHC done, sir.
Varun, what would you have done differently for this patient if you were to be the primary clinician to begin with?
Sir, initially I want to do all the routine examination, and after that his meaning MRI and all, I would like to get.
No, his pre-op PSA was 90. Are you happy with that? With PSA of 90, would you have gone ahead with HOLEP?
No, sir. Initially, I would like to get one DRE done. I want to do DRE, and then I want to reassess, sir, and then get MP-MRI done.
Okay.
To see for external extension, extension of the local prostate.
So you mean to say before going ahead, you would have wanted to evaluate him, get a biopsy done?
Biopsy done after that. Yes, sir.
And then a metastatic evaluation before venturing into any treatment apart.
Yes,
so this is one point which I want to drive home for all the residents. For any case suspected of a CA prostate, elevated PSA, thoroughly evaluate before jumping in for either doing a TURP or a HOLEP. Without metastatic evaluation, going in for architectomy for a non-metastatic disease is an absolute no. So any elevated PSA, any suspected CA prostate needs a thorough evaluation. TURP with architectomy is not a treatment for non-metastatic CA prostate. So that is one point to drive home. So Varun, as you mentioned, for this patient, with the rising PSA, they have come to you, doubling time is being less than 10 months. And as you rightly mentioned, you want to look at the patient in overall status. You want to do an imaging. So this is what the scenario is. Patient is asymptomatic. His performance status is good. DRE prostate is hardly palpable. No hard areas either. His serum testosterone documented a castrate level of 0.0903. and outside clinician has done a CT with chest and abdomen and a bone scan, which is not showing any metastasis. And he also got a DEXA scan, which is showing features of osteopenia. So now in our clinical practice, we are using PSMA PET CT more liberally. Would PSMA PET CT scan would have really made a difference for this patient? Dr. Preet, can you take this question?
Yes, sir. Yes, sir. There's a probability that this PSMA PET could have picked up the metastasis and would have upgraded this disease to a metastatic castration prostate cancer at this stage too, because of it being more sensitive and specific than the conventional imaging, that is CT, whole abdomen, pelvis, and the bones cancer. So it might have upgraded this disease to metastatic CRPC. We have done it at this place.
Okay, fine. Point taken. Well, so this is what it is. We have so far so much information that imaging is not showing any metastasis. Testosterone is at castration level, and his PSA doubling time is less than 10 months. Dr. Gopal, what do you think would be the diagnosis, and what are your treatment options for this patient?
So I would, since his PSA is rising and he's having a castrate level, he's maintaining the castrate level, and on imaging there's no further metastasis noted. So I would like to diagnose him as a non-metastatic CRPC, sir. And my treatment options would be to do a continuous androgen deprivation therapy in the form of surgical or medical, sir. If it's a surgical, I would like to subject the patient to a orchidectomy, which continuously decreases the level of testosterone, or I can subject the patient to a medical ADT in the form of the enzalutamide or a darolutamide, or with the other apalutamide, sir.
Okay, fine. So you did make a note that in non-metastatic CRPC, there are 3 drugs.
Exactly.
And as you rightly mentioned, enzalutamide, apalutamide, and darolutamide are available for us. So if given an option among the 3 drugs, if all the 3 drugs were to be freely available, which one would you choose, Dr. Gopal?
Sir, I would consider initially enzalutamide, sir, because it is 160 mg can be given, and the patient has quite a number of side effects. But even now, DEER trial also has been come up, sir, where darolutamide has been also been proven. 200 mg can be given twice a day, and it has proven to be less toxicity, and the CNS side effects are also less, sir, compared to other ARIs.
Okay. One more thing which I would want to highlight is focus on bone health as well.
Yes, sir.
This patient, as I mentioned, his DEXA scan is showing features of osteopenia.
Yes.
We have to look at his calcium and vitamin D levels, give a sufficient supplementation, and to add zoledronic acid or denosumab in these patients. Dr. Gopal, can you, before starting patient on zoledronic acid or denosumab, what precautions would you want to take in this patient?
Sir, I would like to check his bone health, sir. I would like to check, put him on a vitamin D supplementation, and so that the bone health is maintained. And that's it.
One thing which I would want to do before starting them on either zoledronic or denosumab is to have a dental health evaluation. Yes. And to look at their calcium levels, because hypocalcemia is a real threat in these patients once we start. And even this avascular necrosis of jaw is another dangerous thing to deal with. So maintaining, looking at the dental hygiene and calcium levels would be wise before starting them on either of these medications. Well, as you mentioned that you would have wanted to start the patient on enzalutamide, there it goes. Patient was started on enzalutamide, 160 milligram. However, 9 months into treatment, he started having mild backache, and his PSA went up to 8. And this time, we got a PSMA PET scan, which is showing multiple PSMA avid bony metastasis. What next? Dr. Preet, you can take this question.
So now the patient is being diagnosed as a metastatic castrate-resistant prostate cancer. So usually 1/3 of these cases, as you mentioned in your talk, 1/3 of the cases gets transferred to metastatic CRPC from non-metastatic CRPC in 2 years. So next step, I would take preferably do a metastatic site biopsy, or ask if there's any tissue available from the prostatic biopsy which was done earlier, and do a genetic testing in terms of HRR gene mutation and MMR gene mutation, and which would help me to decide the further management in terms of addition of the PARP inhibitors or another further management for this patient.
Okay. Would you like to look for neuroendocrine differentiation at this point of time?
Yes, sir. I would also do, since the patient has an initial grade of initial Gleason grade group of 5, and also it's not responding to ADT. There is a chance of 70 to 20% of this subset of patient could have a neuroendocrine tumor. So I will ask for a pathological review for the neuroendocrine site differentiation in the biopsy of the metastatic site. And give this subset of patient and treatment, a platinum-based chemotherapy treatment, mainly involving the cisplatin and etoposide, because they're not gonna get treated with this standard line with doxycycline or androgen and ARs, androgen receptor blockers.
Okay. So let's presume that you did get your IHC evaluation and there is no neuroendocrine differentiation per se. What do you want to do next for this metastatic CRPC, Dr. Preet?
So this metastatic CRPC patients, I would give him a doxycycline. Doxycycline, I can give him a doxycycline challenge as a part of a second line management, since he was second line treatment on androgen receptor block, the PSA was raised. I could give him a doxycycline therapy. I could add doxycycline.
Dr. Varun, do you have any other treatment options in mind?
Sir, now patient has already received enzalutamide, and since it is only a bony metastasis, I would like to offer him docetaxel or radium-223, sir. He's also a candidate for olaparib or abiraterone and abiraterone, but PARP is not freely available in India, sir. So if his medical condition is suitable, then I would like to start him with docetaxel, and also I would like to add a bone protective agent like denosumab or zolintomab.
Well, okay, point taken. So as you rightly mentioned, he went on to receive docetaxel, total 8 cycles of chemotherapy. So one thing I would want to emphasize here is in metastatic castration-sensitive prostate cancer, we give 6 cycles of dosi, whereas in CRPC it is 8 cycles. So this patient received completed 8 cycles of dosi and 3 months undetectable, and at 9th month, PSA went up to 2.8. And in 12 months' time, it became 5.8. It has been unrelenting. So now PSMA PET-CT was done. Now it is showing PSMA with multiple bony and nodal metastasis. And there is also a PSMA non-avid, a large para-aortic lymph node measuring about 3 centimeters. So what next? What do we do for this patient? Any one of you can take this question. Dr. Preet or Dr. Gopal, any of you can take this question.
So should I?
Yeah, you can go ahead.
Sir, at this point of the time, so I could give 3 options to the patients. I could offer him a doxycycline re-challenge, since the PSA was raised after 6 months. 6 months of doxycycline was given over 8 cycles. I could offer him a carbexycycline with prednisolone with CSF as increase of better overall survival seen on the basis of CARD trial. I could even offer him lutetium 177 PSMA 617 as a part of a vision trial. So out of these, I would preferably go with the carbexycycline, and lutetium is little bit expensive as compared to carbexycycline.
Okay. Once patient is on cabazitaxel, what are you worried about?
So severe febrile neutropenia, I have to counsel this patient, since there's a high mortality chances if putting the patient on a carbexycycline.
Okay. So this is one patient wherein initially with a raised PSA of 90, he got a HOLEP done and pathology showed as 5+4. Without metastatic evaluation, he was started on an ADT elsewhere, and he came to us with a short PSA.
Ravi, do you want to summarize your overall the last 55 minutes? Because we've got 2 minutes now.
Sure, sir. So
8:20.
Yes. To summarize, one thing, disease biology is the king, especially when it comes to CRPC setting. We have to understand the natural history of the disease and respect it. With more of PARP inhibitors coming into picture, the molecular diagnostics takes a center stage. Metastatic site biopsy would be preferable. If not, the primary site or even circulating tumor cell DNA is a good option. Look for both DNA repair deficiencies and MMR deficiencies in these patients, and try to understand a patient as an overall picture with multiple treatment options in hand. We have to pick a right treatment option for the right patient, with options ranging from chemotherapy to novel androgen receptors to PSMA lutetium and PARP inhibitors. We have to make a wise choice across the multiple lines of treatment.
I'm just going to ask just one question to
Yes.
Gopal. Yeah.
Yes.
Dr. Gopal is there, isn't it?
Yes, sir. Yes, sir.
Yeah. What's the difference between, what's the difference between androgen independent prostate cancer and castrate resistant prostate cancer?
In castrate-resistant prostate cancer, the androgen independent is irrespective of the androgen. The prostate cancer is present. It means that the testosterone levels are irrespective of the level of testosterone. The prostate cancer is present, sir. Whereas in castrate-resistant prostate cancer is basically.
Okay, sorry, I'll just, it was wrong of me to ask you that question. So
Yeah.
the reason why I was saying is in the overall natural history of treating this, so initially you will have castrate sensitive prostate cancer. Okay. Then you would have castrate resistant prostate cancer. But even in castrate resistant prostate cancer, the fact that abiraterone is working, enzalutamide is working, darolutamide is working means the androgen pathway is still intact. The androgen pathway still works. When none of the androgen medication work, androgen pathway medication work, the overall pathway totally shifts. And then in that situation, only chemotherapy works. So in the history, you should always know, is the androgen pathway, is the androgen receptor is still relevant or not? The moment you say that it's irrelevant, we are only left with three: docetaxel, cabazitaxel, and we have to go down the line of lutetium treatments. Yes. Unless it has gone down the line of the neuroendocrine differentiation, then the other chemotherapies come into play. Okay. So that's one thing that I wanted to emphasize. The second thing is the 4 timelines that I said. 2004 was the docetaxel. Yes. Then came the 2013, the radium-223, which is a predecessor to the lutetium-based treatment or the new actinium-based treatments, saying that radiopharmaceuticals do help in achieving biological response, not symptomatic response. We are altering the natural history. So though we tend to think that they are only taken up in the bone metastasis, it does seem to alter the natural history. Okay, so that's the reason the 2013 one was important. Then we have the newer hormonal agents wherein we thought there was no role for androgen receptors. Now we know that the cells tend to manufacture, or there is still androgen receptor relevant. That's why we have got all these molecules working along the same pathway, still giving us OS benefit as well as biochemical benefit. Okay. And then the latest one is, when all these things have gone, is the targeted treatments, which are either olaparib or rucaparib or niraparib or any of those things. I just want to end this. There was this study done whenever I think NMCRPC is hen's tooth. We don't find that in India. Yes. The reason is when they did a study on almost 200 patients who were categorized as NMCRPC, they had a PSMA PET. 99% of them had metastasis. So the moment you have PSA doubling time less than 10 months, they are positive on the PSMA PET. So NMCRPC, I feel it's a drug company defined. It is, yes, if we diagnose it, it is good to treat it, but we rarely diagnose it in India. So NMCRPC is good to know, but you rarely find that as a disease. Okay. Anything else that you learned? I'm going to ask 3 of you. I will come back to you, Gopal. Dr. Varun, tell me one thing that you learned today. I'll come back to you, Gopal. So think about what did you learn new thing. Varun, go ahead.
Yes, sir. Sir, I learned first how to, sir.
1 point.
Sir, the entire session was very helpful, sir, for us.
No, I didn't ask for that. 1 point extra you learned.
Sir, along with androgen, androgen independent pathway is there, which we should be alert about it, Anta, sir. And we should see the intact, whether the hormonal pathway is intact or not, sir.
Yeah. Okay, I'll tell you what I learned new. Preet Mohan Singh, what did you learn? One thing.
Neuroendocrine role of neuroendocrine differentiation and and whole sequencing at the first line, second line, third line. The sequencing, the pattern, how to treat these patients in a castration process.
Gopal, what did you learn?
The sequencing of pattern of treatments on the first line, second line, third line, and the non-metastatic CRPC treatments. But like you said, it's not.
There was one slide wherein Ravi showed the mechanism of action or the side effect profile of abiraterone acetate. I didn't think it caused castration. I didn't think it lowered the testosterone level, but he said that it does lower the testosterone. The lowermost part, it said dihydrotestosterone, it is lowered and causes castration. But it doesn't cause enough of a castration. If you just give abiraterone acetate, the levels of testosterone don't touch below 50 on a consistent basis. That's the reason you have to give ADT along with abiraterone acetate. Whether we need it, ideal, because if we are saying that the ADT pathway is still relevant, you have to ensure that there is castration before you add in any other medication. Okay. Thank you very much, Ravi. Anything else that you learned in the preparation? One thing, Ravi?
Sir, role of genetic testing, sir. I think that is one thing which is less said and less spoken about. So during this preparation, I did read more about role of genetic testing and molecular diagnostics. Sir.
Thank you very much.
Sanjay,
yeah.
Sanjay, can I have a word?
Yeah.
Just wanted to tell the participants that once the patient reaches a CRPC status, there is one thing that is going to definitely happen is death. So be very careful when we will learn the sequencing. We know what to give next and what to give next after that and all. But keep in mind, you are not treating just the PSA races or a new onset of meds, but you're treating the human being as a whole, and quality of life matters a lot. And therefore, keep that in your mind before venturing into each new treatment. Sanjay will remember when we were in training, we were told very clearly, don't even bother to treat any raising PSA. We'll start treating only when there was symptomatic metastasis. So we have moved the goalpost a bit, but still keep in mind that we are treating human beings and we all know that they will die eventually. Allow them to die peacefully. As long as you're ensuring the peaceful exit, all is well. Thank you.
Okay. Ganesh, anything you want to add?
No.
Oh, Ginil? Sorry to wake you up, Ginil. Okay, that's fine. Thank you very much. Thank you all for your participation. Yes, and thank you, Ravi.
Thank you, guys.
Okay.
Bye.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.